Yes, hi, welcome guys, hi. So I'm speaking with Eva Contractor and Saga Sharma today. They both work for the NHS. Do you guys want to tell us a little bit about your role?
Yeah, so as you said, my name is Eva. I work for the Royal Free Hospital in London and I am a physician associate in urology. So essentially I work as part of the medical team, but I'm not a doctor. That's essentially what I do.
Saga?
And my name is Saga Sharma. I work as a junior doctor at the University Hospitals of Leicester, currently working in acute medicine.
So you've said a physician associate, so what exactly is that in comparison to a doctor? You said that you're not entirely a doctor, but for those confused at home, what exactly would that entail?
So essentially what we do is we train under the medical model, so we're there to support the doctors. So on a day-to-day basis we do similar things, but we're not doctors. We can't prescribe medication and we also can't give radiation to patients, so ordering x-rays and CTs and things like that. But day-to-day in terms of managing patients we do very similar things.
Perfect. And obviously, as you know, I am from UKAT, so I'm sat down with you guys today. And UKAT is one of the leading, if not the leading, UK addiction treatment here in England, obviously given by the name. So we are essentially about to sit down and just talk about addiction as a whole and what you guys see from your standpoint working within the NHS, because alcohol is a very casual factor for many medical conditions and issues, including cancer, liver failure, of course addiction, which all inevitably can lead to death. So how do you guys recognize that when patients get admitted?
So obviously for Saga it's different because he deals with the acute medical side, so he probably sees a lot more. But for most of us, we see so for alcohol, we would see them presenting with withdrawal symptoms. So it's usually at that point that they present, or they present with a different medical condition that's unrelated, but at the same time, they will have withdrawals and then you end up sort of going down that route at the same time. Or they end up being admitted with complications of alcoholic liver disease.
Saga, do you find that's the same for you? Eva mentioned it could be slightly different.
So in my experience, so working in acute medicine, so what acute medicine first is where you see patients right when they're referred from an A&E team to our medical team. So we often see a lot of patients presenting with overdoses. So overdoses related to alcohol, related to multiple drugs, related to other medications. And often when we see these patients, they're not patients that have just come in once. We often see patients repeatedly attend. That's how it comes to your mind, could this patient be an addict, for example? And then certain things in their medical history make it more apparent. So if somebody, for example, is on a medication called methadone, if you're on methadone, essentially, you may have been a heroin addict in the past. So in different contrasts, we see it differently.
And does this shape the way you approach the patient? Because I imagine there's so many medications that you guys can use, and ethanol might be something that you have to use within your day-to-day with regular admission, like the average patient. How do you go about the different medications and what you're allowed to do, what you're not allowed to do when someone does have an addiction, not just for alcohol, but any sort of substance?
Might be better answer.
With regards to firstly thinking about the substances, obviously medications interact and treatments interact with various things. So if you know somebody's, for example, an addict to alcohol, there are certain antibiotics you can't prescribe, thus limiting your treatments. There are certain conditions they may have as a result of addiction as well. So for example, you mentioned liver failure. If patients have advanced liver failure, there are some medications you can't use. Some antipsychotic medications, some antidepressants, some antibiotics you can't use. So it does limit things.
Great. And well, that's not great, obviously. That's it. But thank you for answering so honestly and candidly, because it's quite a difficult situation and one that you must face, unfortunately, quite a lot, because addiction is such a widespread issue but not so widely spoken about, which again brings me back to the NHS in general, because they have got lack of funding is already an issue for you guys, which I'm sure is quite a subject that you guys have spoken about with your colleagues, with yourself, what you've thought about in terms of how you've managed to get to the position that you guys are in now. It must be quite a frustrating thing for you guys individually as well as for your fellow colleagues in the NHS. But how much money realistically goes behind the treatment of addiction overall for NHS? Do they really focus on addiction? Do they focus on people with drug issues and alcohol issues when they come to the NHS?
The brutal answer to that is no. Because there's barely funding to treat the important conditions, and this is very important as well, that they focus on people who, on people who have not contributed to their disease, if that makes sense. So if you have an alcohol addiction, for example, you're not going to be prioritised from that perspective because there's just not enough funding. And I assume that in the NHS there aren't really rehab programs because of that.
I see. So you're almost likening it to someone with obesity, for example, that the NHS wouldn't look as fondly as that as someone coming in for cancer treatment. Is that the sort of aspect?
It depends on the situation, because actually a lot of cancers are also linked to obesity. So it's a grey area, but if there's an obvious thing, then yes, it can put you at a disadvantage.
Saga, do you have any sentiments to add on to that? Or?
Exactly as Eva said, it unfortunately, addiction is a medical illness and we know about it, but there are certain treatments and funding that you may not be eligible for if you're an addict of certain sorts. So, for example, I work a lot with kidney transplant patients, and in any transplant medicine, if you're an addict to any substances, you're not eligible for transplants. So, for example, if you needed an urgent kidney transplant, liver transplant, heart transplant, you simply would not be eligible for those treatments. And also with regards to, we just went through a COVID pandemic, for example. During the pandemic, a lot of patients went to intensive care, and often patients who've had significant medical illness as a result of addiction may not be eligible to go to intensive care. For example, those with advanced kidney failure, those with advanced liver failure. So it does put limits on things, and unfortunately there isn't much funding for it at the moment.
I see. I was going to add to that actually, because you were talking about like transplants, and in patients with alcoholic liver disease who reach end stage, the answer is to do a liver transplant, right? Because you need a new liver. But those people will not be eligible unless they've been alcohol free for a year. So already, if you're not, which a lot of people will not be, right? Because they're struggling. So you end up in a difficult situation.
For the addict themselves, what would give them that boost to go and seek help then? Because if you're saying that they're going to be last on the list or they need to be alcohol free for a year, some people can't even get through the day alcohol free or even substance free. So what, in your professional opinion, what could be the benefits, rather than quite an extreme example of like a kidney transplant or a liver transplant or so forth, what would be the overall outcome and benefits for someone to become clean?
So, to say, there's a lot to, obviously lots of things that can be covered about the benefits of being clean, but I guess it overall improves your health, improves both all your mental health, your physical health, your emotional health, and often what I experience from patients who are addicts, again using the term with a bit of caution, is that they often have this mental cloud over them where they just can't think straight. So unless they either are under the substance or under the what you call being high or having alcohol, being drunk or so they can't use their minds, and often you need that clear thought process by which to make these decisions. But again, it would just clear your mind, and it just provides benefits in many health conditions.
And not just for the patients themselves, but overall, if you're treating these people how they should be treated and getting, well, I wouldn't say getting over the addiction, but being able to address it, it would actually boost the economy a lot, because those people are usually at the point where they are entering hospital. They're not able to work. They haven't worked for many years. they've completely lost their relationships or support networks. And actually you end up not only treating the addiction if they even get to that point, you're also treating a lot of underlying mental health, because they're not working, they are therefore having to be supported by the system, right? So actually, obviously there's patient benefits, but there's overall benefits as well.
Yeah, social and economic
Exactly.
and individual benefits overall.
For example, recently for the treatment of diabetes, they've approved weight loss injections, and there's a big talk about putting out these weight loss injections to people on benefits for
Are you talking about Ozempic in particular? Yeah. Okay.
that also needs to be looked at. Again, with addictions, you're off work, like Eva said, you're not contributing to the economy. Again, that creates a negative view, so there would be a huge economic benefit.
Yeah, that's all very, very valid points, and one that not many people look at because they, as most people do, it's very human instinct to think of me, myself and I, or my family and loved ones, and that's all I care about, very closed off. But in the grand scheme of it, addiction overall is a very widespread issue that does affect the economy as well, and affects not just the individual, but it also kind of ricochets onto the family members too, because it can cause dependency in enabling, it can cause stress, depression in others, not just the addicts themselves. So it is a very wider issue. And when you guys are obviously in your respective hospitals and you're having an average day, how often do you see a patient admitted with addiction signs or withdrawal signs? Is it a regular occurrence for you guys?
So for me personally, there hasn't been a day I can think where I haven't seen somebody related to addiction. So either somebody who's an alcohol addict or somebody who's taken drugs in the past, and it's very uncommon that I don't see it. And sometimes you can tell by the nature of someone's medical history. If somebody's, for example, allergic to some of the medications we use for alcohol addiction, you can tell that that patient's been an addict in the past because those medications have been tried. So I don't think there's been a day in the last 6 years I've not seen somebody addicted.
It's very, very, even if you accumulate one person 5 days a week over 6 years, that's a very large number. Yeah. What about yourself, Eva?
I mean, I don't see it every day, but when I do, it has pretty bad outcomes for our patients. So usually what I've seen, and this is probably not a good reflection, sometimes what happens in healthcare, but sometimes what's happened is the patient has come through A&E. Obviously, not everyone is honest about their alcohol intake and things. So then they end up with a different issue. So in my case, because I work in neurology, they'll come in with some neurology issue, get admitted onto the ward, and then you end up seeing the withdrawals things. So we had a patient who had a seizure because it'd gone unnoticed that they were drinking alcohol. So by the time they got to us, they had the seizure. Then we had to do the whole seizure workup and then realise, okay, actually it's his alcohol intake, and then you go down that pathway. So we see things like that, but also, for example, I had a patient who he was in his 30s, had kidney cancer, but was also a heroin addict, but to the point where he actually didn't receive treatment for his kidney cancer. By the time
he got put low on the list, is that what you're saying?
It wasn't just that he got put low on the list, he wasn't attending his appointments, it got delayed. By the time he came to us, it had spread everywhere. And it was so bad to the point where he wasn't staying in hospital for his treatment. He was leaving the hospital to go and get cocaine. And the thing, not cocaine, sorry, heroin. And the thing is, you can't stop patients from doing that because they have the capacity to make that decision. So that's the kind of things we see.
Have you guys ever had loved ones come up to you and warn you as well that, you know, my boyfriend or my husband, my wife, my kid, they're addicted to something? Are they quite candid about that when they reach the hospital?
They are quite candid. I would say overall they are quite candid, and I think relatives, you can see the struggle in relatives, you can see the struggle in friends, you can see that they've obviously been through a lot, and they are openly they're quite honest about the addictions that their loved ones are experiencing. And in my experience, they will tell us, for example, a patient a couple of weeks ago said, "Oh, this is my husband, he drinks a bottle of vodka a day." And they're quite honest about that.
It's very widespread. Obviously, I work in the addiction section myself, so I see it a lot, and it's interesting to see it from a different perspective, because it's inevitable that I will see and hear about people with addiction every day due to where I work and the company that I'm so fond of working for. So for you guys to come and essentially show it from your point of view, it just shows that the figures online and the statistics online aren't exaggerated, that they are true, and addiction does affect nearly everyone in some sort of capacity, whether they know someone from work or they have someone that they love or themselves. So yeah, it is quite a striking number. And so obviously you've mentioned about medically dealing with the patients when they come in for something that is not related to their addiction or kind of concurrently relates to their addiction. But how do you go about interacting with the patients themselves? Do you notice you act in a different way? Are you a bit more blunt? Are you stricter with how you deal with those patients, or do you keep the same courtesy, so to speak, to everyone that comes in?
So medically, it's always the same courtesy to every patient, but I think we're more aware of how these patients may respond to certain things we say. So often these patients are known to be some of the people who are slightly more aggressive than other patients, or a bit more likely to have altercations with staff, and sometimes it's the patient that you'll go and see which has security around the patient. And obviously there is a reason that nurses or other healthcare members have called security. So while our interactions don't change specifically, you are sometimes a little bit scared or a little bit apprehensive of approaching these patients, and sometimes it can affect the way you think about them. But again, the treatment and the courtesy and the interaction doesn't necessarily change.
That's good. I'm sure that's reassuring to many of our listeners and our watchers today, because it's something that people may be scared. So I know personally, in the position, when I see people seeking help for addiction, it's mainly their loved ones that come to us and tell us that they're worried about someone. It's very rare that the addict themselves, because obviously denial is a very big factor within addiction. So when it comes down to people seeking help medically overall, I'm sure there must be some worries about if they're not openly acknowledging their addiction yet. You mentioned someone came in for heroin, an illegal substance within the UK. Surely some people must stop themselves from seeking help medically at all from you guys, or in general, because they're worried that they're going to get in trouble for their substance abuse. So how do you go about that? Is that a confidentiality aspect that you guys have when you're working with people with substance abuse or illegal substances, for example, or do you have to make it known to the law?
As in, you mean if they disclose that information, does it go down in documentation?
Documentation, because that would be private anyway. It would be their medical records, I'm assuming, so that would be confidential anyway. But I'm trying to see if basically reassure people that if they need to seek help, that going to a hospital despite having an addiction won't cause any sort of repercussions lawfully, is basically my question. And if that is the case, how do you go about doing that in your positions?
So to bluntly answer that question, there will be no repercussions in the law for any addict seeking help for any substance, alcohol, drugs, or anything like that. All medical things are kept confidential. So let's say a patient comes in and says, we use this much heroin, we use this much cocaine. We are not obliged, nor do we tell anybody else, including the authorities, the police. Now, when it becomes, often these patients unfortunately are involved with criminal issues sometimes, and when that issue comes to front, then sometimes we have to disclose certain information about the patient, because again the police has asked for the information, and there is certain information when others come to harm or other groups of people come to harm that we have to disclose, but otherwise there is nothing we do disclose.
And so you guys would recommend and full-heartedly encourage people to be completely truthful about their addiction when seeking help from the NHS?
Yeah,
definitely.
Have you guys personally noticed any ongoing trends or more substances that you've seen in other people over the few years, or because you guys have worked in your industry for a long time? So have you noticed any ongoing trends or any spikes with any certain drugs?
So with certain drugs, I haven't noticed any trends with certain drugs or anything, but certain times of the year it becomes more prevalent, or during COVID, unfortunately, due to the nature of the pandemic and people losing their jobs, and there was a lot of negativity around, I think addiction was seen more commonly. And while it was seen more commonly, there was also people seeking less help because they were worried about going to the hospitals and worried about catching COVID. But overall, I think what the weather can have differences, the time of the year can have differences. Obviously, the pandemic and where people are in their lives has a big difference.
Do you have anything else to add in terms of COVID trends you saw? Because I know the media focused a lot on alcohol addiction overall increasing during COVID, because obviously people were only allowed to leave their house to go shopping, and what can you get in the average supermarket is alcohol. So you've noticed also the spike in drugs as well. Yeah. Okay.
Still say though, alcohol is probably the most commonly seen, or perhaps the other things aren't disclosed as much and the focus tends to be on alcohol.
Do you think maybe it's because alcohol is so easily accessible that people do, and it's so socially acceptable as well, that people fall into this pattern? Because when you think cocaine, you think, oh, that is a drug, you have to actively go out and to seek that, and for me personally, I wouldn't know where to start. So it's something that not everyone has access to, whereas alcohol, all you have to do is walk down to your nearest shop, as we said. So do you think that could be a factor in that?
It could be that, but also I think it's related to the complications of each of those substances. So alcohol, unfortunately, has a lot of horrible consequences, and a lot of people will not have a choice to come to hospital because they will end up with those complications. As severe as, for example, like vomiting out blood. That's, at that point you have to be there. So I think that's why a lot of people from alcohol addiction with liver disease end up there, and that's how we see more of those compared with other, let's say drugs, for example. Yeah.
And I think the other thing to add there, like Eva said, I think there's differences between buying alcohol, for example. Alcohol can be a lot cheaper than buying other drugs. So accessing other drugs like heroin, cocaine, cannabis are a lot more expensive drugs compared to necessarily accessing alcohol. And the other thing we see is that while alcohol, like Eva said, has a lot more complications. So, for example, if you see somebody seizing on the street, someone who appears, you obviously seek medical help. Now that could be a withdrawal seizure. Or you see somebody vomiting blood up in a club, or you see them on the street, or you see them wherever you see them, you can see the complications of alcohol more. And I think that's where it's more widely accepted in society. Like, not everybody on the street will know that vomiting up blood, not everybody on the street will know how to recognize cocaine or heroin addiction, but alcohol addiction has a smell, people know the complications, people know what it looks like.
Yeah, no, that's a very good point. You've mentioned withdrawal symptoms quite sporadically through our talk today, but you've mentioned seizures, and now you've mentioned a smell, and now and vomiting up blood. Are there any other withdrawal symptoms that people can look out for? Because they may be listening today or watching today and thinking, oh, I have an inkling or I have a suspicion that someone I love or know has an issue with alcohol, for example. What sort of signs can people look out for from your medical opinion that they can easily look out for, that wouldn't be too difficult to distinguish for the average person who hasn't studied for 10 years?
So in terms of withdrawal, you kind of go through every day after you stop drinking alcohol, the symptoms change. So, for example, in the first day, you might notice people being a little bit agitated, being a bit restless, pacing around a little bit, just not thinking clearly. Then you can recognize people sweating, where you get hot flushes, hot sweats that don't seem right to somebody. For example, let's say you're working with somebody and they're pacing around the room, they look a bit restless, they look a bit agitated. Then often when you go into day number 2, you may get hallucinations, you may see or hear things that you don't that aren't there, and then moving on to later on in the pathway you get things like seizures, which Eva talked about, and that's often where you see that in hospital.
And do you feel that there are some common misconceptions from people that come in seeking help from you guys as doctors and PAs, and they or even from their loved ones, because they may denial, as we've mentioned, is such a strong and very powerful step that many people struggle to get past. It's I always say it's the one, because denial can be so strong and we can all manipulate ourselves so strongly, and we can also gaslight ourselves into thinking that our loved one's okay. So when you come across and you say, I think this patient has withdrawal symptoms for a substance that we need to look further into, do you find any pushback from loved ones? Because it might be quite inevitable for the addict themselves to try and hide that and try and push that and deny that as much as possible. But do you guys get pushback from their loved ones who think like that's not true? I don't, because I'm with them all the time. That's not true.
I've actually found the opposite, because from my experience, by the time they're in hospital, the families have usually had to deal with this for some time. So actually, I've never encountered any resistance. If anything, they're so grateful and desperate for help for their loved one. But I don't know what you've experienced.
99% of the time I've experienced exactly the same. The only time where there has been misconceptions or something is when, let's say, that they don't know they're drinking that much, for example, or not even in that way, where sometimes people don't view a bottle of wine a day as, for example, addiction. They just view that as the norm. And that's the only time I've experienced some pushbacks, but otherwise they're more than grateful, they're more than happy to say whatever, be open and honest and have the full conversation.
Yeah.
And how well equipped do you think the NHS as a body is ready to handle or can handle all of these cases or patients with co-occurring addiction as you're trying to treat them? Because it must make a difficult job that you guys have just that more difficult when you have to go and try and make sure that the issues from withdrawal or previous or if they're currently suffering with addiction, it must make it that much harder. But do you think the NHS is well equipped overall for that? That's a difficult one, I know, from the position that you guys are in. That's a difficult one, I know, from the position that you guys are in.
I would say, yeah, like you said, Victoria, it's a very difficult question to answer. I think every hospital, every health service around the country is different levels of equipment, but I think while we are equipped, we have shortages in every domain. So, for instance, if a patient with addiction and a patient withdrawing requires more support, they often require one-to-one staffing. When they're acutely agitated or they're acutely withdrawing, that the person requires constant attention, and sometimes that staff member is just not there. We don't have the funding to have that many one-to-ones in the hospital. And other things, for example, where you need more high acuity care, for example, you could do with more doctors around, you could do with more medications. And I don't know whether this was a widespread issue recently, but one of the medications we use for alcohol withdrawal, Pabrinex, have a national shortage. And now the national shortage can only be because it's being used so much or there's no supply, but clearly there was supply-demand mismatch there. So it just shows how bad the problem is.
Yeah, no, I didn't even think of medication shortages, because even recently we had the antidepressant shortage and we had antibiotic shortages. So yeah, that's quite interesting take that I hadn't thought of before. Do you think that this is where the benefit of private rehab facilities come in? Because you guys mentioned a shortage of just being able to cater to someone with addiction so acutely. Do you think that this is the benefit from rehab, where they can focus on someone individual?
Well, personally, yes, I would say so, because in the NHS, they will only deal with the acute part of your addiction. So in the case of alcohol, you come in with withdrawal or whatever you've come in with, and then with the withdrawal symptoms. And so you sort of get a detox whilst you're in hospital, but then probably all of patients who suffer from any addiction have underlying like mental health things that require a lot more input than just some medication for a couple of weeks, right? It requires a lot of social input, a lot of psychological input, and that is just not there in the NHS. It is, but it's not easily accessible. The waiting times are very long, and it's not like a rehab process where you go in for a detox and then they focus on solely you and you have like weeks or months of just, purely addressing the addiction. That's not something that exists in the NHS.
Yes, so from my perspective, I completely agree with Eva. So as soon as I admit a patient, as soon as I see a patient, the first thing that a manager or higher up a person will ask you is, when is this patient going to be discharged? And that's the first question you get asked, like, what's the estimated length of their stay? And so there's such a focus on discharge in the NHS to try and free up beds for other problems, I don't want to say more significant health problems, but health emergencies that often once they've got over that acute period, there's such a focus on let's get this patient out of hospital that we've not actually been able to solve the underlying issue, which might be a mental health problem, which may be psychological, which may be social, and we've never actually get to the bottom of that problem that may have led to the addiction, because simply there aren't the services or the beds or the inpatient care to allow that. And often you just refer this patient to, they've been referred to Alcohol Anonymous, they've been referred to the substance misuse team, they've been referred to the mental health team, but there's very little time to actually follow up on that. And it's often like, oh, this can happen outpatient, but when the person leaves hospital, again, they have access to the substance, they have access to the same people, and often they just come back into it.
And it's such a shame because, for example, with alcohol, it's the third most preventable disease globally, especially within the UK, and you would think that the NHS would put more money behind that, especially if it's preventable, because it's something that people can be essentially not entirely cured from, but something that they can work towards a sober life for, which is obviously good numbers overall for the NHS, because if you look at it from a very broad view, they're going to look at the amount of patients that come in, how many people come back out, so in the broadest of ways. So why do you think, just to give a bit of more perspective to everyone out there, why do you think that the NHS isn't putting its money in the addiction section itself? Like, what else is the NHS dealing with from your perspective that isn't putting its money in the addiction section itself? Like, what else is the NHS dealing with from your perspective that they're not being able to put it there?
Okay, so to put it very brutally, honestly, within the NHS, whenever you do anything, the cost has to be justified in some way, right? That is how everything works. Like, our job roles, for example, have to be justified, otherwise we won't be hired. And if the benefit of treating addiction is overall not benefiting the system, then the cost to put into those patients is not going to be justified. So they won't do that, because they've obviously done, I assume, a lot of studies on different health conditions and what the cost of these things are and the outcomes for those patients and what they contribute to the economy and all these things. And I think that's probably what plays a huge role in treating addiction. But that goes for like so many other things. For example, there are many screening programs for cancers, but why do you think some are focused on and others are not? Like, there's a bowel screening program or a cervical cancer or breast cancer screening program, because we know how common those cancers are, and if they're treated early, it can save life, but also a lot of money going forward. So all of what I'm trying to say is that, yeah, the cost has to be justified, and perhaps it just isn't in the NHS at this given time.
Okay.
I'm going to put you on the spot here, but be free to be free to just bite back if necessary. Because earlier on you mentioned the economic value of saving someone or helping someone with addiction. So I know you don't represent the NHS overall, but you guys are here sat down with me today representing them. So I'm going to have a little go. But in terms of, if you've said that can help them overall, and it can help, just you're saying that the NHS needs justification for the outcome of helping someone, then why is addiction not higher up on that list, considering, especially alcohol addiction, considering the sheer amount of people that in the UK that have to deal with it, and that are suffering with addiction or battling against it? And economically, we've already established between the three of us that would be beneficial for the country. So why is it still low on the priority list for the NHS?
Well, coming back to the cost thing again, I don't know how much first of all, I don't know how many patients as a percentage of overall health conditions patients with addiction take up. But second of all, I don't know how much cost that actually involves. So it's hard to answer that, because although, yes, it would improve those people's outcomes and contribute to the economy, but perhaps it's not enough to justify putting the extra money into the NHS, because perhaps the cost of treating those patients is actually more than what they would contribute to the economy. I don't know the statistics.
Of course.
So that's why it's hard, even though that is my opinion. But the reality is probably someone's done the maths, you would hope.
Do you think relapse has something to do with that? Because relapse is always something that could occur for someone in sobriety, and it's obviously, once you've overcome your initial addiction with the help of rehab and detox and so forth, staying sober is an ongoing battle and something that people will have to live with for the rest of their lives and keep that willpower going. Do you think perhaps it's the relapse potential in those people that makes the NHS hesitant to put the money behind it, because it could be deemed as wasteful for them?
That's it's a very difficult question to answer, but I think there is an element of where there is wasteful money and useful money. Like, for example, let's say there was a patient who's been now sober for 5 years and they apply for a job, for example. As part of a lot of job applications, you have to give your health history. Now, let's say you're somebody who's completely sober, but you have liver failure. You can look well, you can still work, but you've had alcohol-related liver failure, and again, you've declared that to your employer. While we have clear rights of employers and rights of employees to have that confidential, sometimes it can affect your employment aspects, it can affect things. People may not want to hire those people. And again, I think while there is a huge benefit in terms of finances in treating addiction, I think looking at the individual cases and looking at certain things, it's still difficult for those people to return to work and for those people to effectively stay sober and to stay into returning to work. And again, while we say there isn't funding, recently in the last year, again looking at another substance, tobacco, there has been a lot of funding in terms of tobacco treatment in the last year. So for example, the hospital I work in the last year has had a tobacco treatment service. So every patient who comes in with a smoking addiction or who's a smoker, we have to refer to the service to try and get them to stop smoking. And there's been a lot of funding purely because of this, because of the burden of lung cancer costs to the NHS. So I think, again, looking at the economics more specifically, while me and Eva don't know the exact figures, I'm sure someone has done the maths to look at this. And especially with smoking, for example, I think New Zealand has tried to do a smoking ban, Germany's tried to do a smoking ban. So I think that's one of the substances which does create high cost and high burden. Alcohol obviously does as well, and other drugs do, but the economics may have not made as much sense.
So overall, it's just the NHS is stretched very thin in terms of their budget and what they can allocate that to. Exactly. Overall. Yeah. Okay. And what sort of support do you guys find when you're working and you've got someone who may be particularly difficult and maybe dealing with addiction, do you feel that you guys are cared and protected when you're working and having to deal with people that are going through such extreme withdrawal? Because obviously in a private rehab facility, having medical observed and medical monitored detox is something that is provided and something that is expected, because you're being looked after and you're going in for the sole purpose of detoxing and overcoming the psychological battles that that may be fueling your addiction. But do you feel protected? Do you feel that you get enough support, even if it's to talk to someone at the end of the day if it's been a particularly difficult day?
I would say for all things like this, support is mainly colleague to colleague in the NHS. So there are services you can approach with your NHS employer. I'm sure there's NHS counselling services, there's NHS like psychiatric help, and you often do get that help quite quickly if you need it. I know colleagues who have gone for certain help related to patient factors and where things can be a bit too much, but often it's you go for mental support and physical and emotional support to your colleagues, and they've been through the same thing, they go through it day in and day out, and I don't think there's a lot of money or there's a lot of certain emphasis on protection for doctors, healthcare professionals, nurses, PAs, and I don't think necessarily in our training that we are necessarily prepared for this as well, because you are prepared for a variety of things, but I don't think addiction is one of the things that the training necessarily focused on either.
Yeah, of course, because of the therapists and the doctors I deal with on a daily basis, they're all trained and they're all specialists in the field of addiction, and they either have the background themselves where they understand about addiction, or they're very closely linked to it. So that's another aspect that I haven't thought of in my position, that you guys aren't being trained entirely for people with substance abuse, and that must be something that you have to wrap your head around, especially at the beginning when you guys first started. That must have been quite a drastic thing, because you're not just dealing with the average patient coming in with chest pain. You have to look at the wider picture of it, and sometimes what's not being said, and the clues behind the medical reports that you're getting, or the blood tests that you're getting back. So yeah, I can imagine that overall must be a very, just like adds extra puzzle pieces to your daily job with the patients, I suppose, overall.
Yeah, it does, because we're definitely not prepared for things like aggression or behaviour like that. And for example, you may, let's say this was a night shift. I don't personally do them, but I have heard from other colleagues where if they are stretched particularly thin overnight, and if it's, let's say, a female heavy team, they obviously don't have the same strength as a male most of the time. And if there is a patient that is particularly combative or hallucinating things related to, let's say, alcohol withdrawal, then it can be really difficult to deal with that, because they are literally on their own, and a lot of the time then they need to seek advice from the junior doctor that's on call. Now that might be an F1 who is in their first year as a doctor, and then they have to come along and assess the patient as well by themselves and come up with a plan, and potentially if the patient requires some sedation or things, these are things that they're having to do on their own in the middle of the night. So we're definitely not prepared from that perspective.
Yeah, I see. Yeah, that's I can imagine that can be quite intense for people overall when they're all in a job already, or profession that is already deemed quite difficult, and obviously a necessity within this country and globally. So in terms of the waiting list for addiction treatment, because I know you mentioned that it wasn't quite as a popular route that people do go down, but there are options. There are NHS options for free treatment, for free addiction advice, and free help, which most people would want to or feel inclined to go to before they start researching their rehab facility options within the country. So you may not know the exact answer, but from your experience, what's the average waiting time for someone from when they first call the NHS addiction treatment section until they get that help, or until they get seen by someone for the initial kind of assessment that is obviously needed when someone goes?
Really, when speaking to patients where I work, maybe 1 to 2 weeks has been, and again, that won't be seeing somebody physically. Often, as a result of the pandemic, we have this new concept of telephone consultations or virtual consultations. And again, in virtual consultations, these patients are quite good at putting themselves together and not being open and as honest about certain things, and you may not find out a full story. But in terms of waiting lists to be seen by these places, probably 1 to 2 weeks in my area. Sometimes if it's specific substances or specific things that are required, it can be as long as a month.
I was going to say probably longer in London from my experience.
That's so long. For example, with UKAT, if someone calls our admissions team, which is already free advice, they get seen straight away. If someone calls someone on the other end, someone who deals with addiction and is a specialist and is part of our team, will answer straight away, and then if they need help, they can get a bed as soon as the next day, depending on who and how needed. That's obviously it is a paid service, so you're getting what you're paying for, but it still shows the drastic difference that you can receive help the very next day if that's something that is a necessity. But if someone's in the same position going down the NHS route, but even a month that's really long. Even longer. That's
services. Your facility in particular works 24/7, works every day of the week. So often, like the substance misuse services in the NHS don't work weekends, they don't work evenings, and there's often restrictions on these things and getting the help. Often some of these people who are addicts are still working, and they'll be working alongside the substance, and they may not be able to call during work, they may not be able to make these appointments, they may not be able to take time out. They may want to call in the evening and speak to somebody, they may want to speak to somebody at the weekend, and again, that only lengthens things, and then you get questioned as a patient by your employer, why are you taking time off work? Are you unwell? And I don't think patients necessarily want to say, I'm getting addiction help. So that only lengthens the waiting period.
Yeah, the hesitancy, the difficulty in disclosing everything 100% to everyone around you, which is a shame, because most addiction rehab facilities, private ones, including UKAT, is all confidential, and it's very much a question of making sure that the person on the other end of the phone is okay, because sometimes people just call because they're worried about their loved one, and they're just saying, I think this person's, for example, my son is drinking this amount every day, is this a problem? Sometimes it just takes a reassuring ear. Sometimes it's someone on the other end of the phone saying, actually, that's an issue, that would be classified as an addiction, and then it gets the ball rolling. So yeah, it's a shame that the NHS services are stretched so thin, but that's where the private rehab facilities like UKAT come in. So in your professional opinion, or even your personal opinion, what do you think about private rehabilitation facilities?
They're extremely important in healthcare, and I think they play a huge role in getting people back to being sober, and I think it's great that they exist. They really should exist in the NHS, and I think, like we spoke about multiple times, funding, staffing is just not available in the NHS, and I view these facilities with great respect for the work they're doing, with great just honour that someone is doing the work that the NHS is unable to do. And I think I've seen patients who've gone to these facilities and benefited greatly from these facilities, and they'll tell you that they got the time, they got counsellors, they got a whole team around them, they met other people who were also addicts, they got treated quicker, they didn't experience any of the things that you experience in the NHS, and I think they play a huge role in bringing people back to sobriety and mental and physical health.
Yeah, no, I agree. The only issue is access to funds, because most of the people, at least that I have seen in hospital who suffer from any addiction, a lot have actually ended up in a situation such as homelessness, and have absolutely no support from family, friends, so therefore, and don't have a job, so don't have any finances that would actually enable them to access a private facility. But otherwise, yeah, I think they are absolutely necessary. Otherwise, I don't know how those patients would actually ever recover.
Yeah, overcome their addiction with that. It feels very isolating, addiction. It makes people feel that they're entirely alone, and that same can go for mental health issues like depression and anxiety. Everyone, and I've had those initial anxiety bouts as well, where you think, oh no one's going to feel the way I'm feeling at this exact moment in this time. But it's a very universal feeling. Emotions are meant to be felt, and emotions are meant to be dealt with, and some people just need that extra help sorting through the chaos within their mind, or sorting through trauma, PTSD, or depression, because it's no one's fault that people emote the way that they do. It's when people pick up a bottle, or they start using cocaine, or they start using heroin, or MDMA. There's so many different substances out there that people start to use them to felicitate, just not feeling so alone, and perhaps ignoring their feelings, which is obviously the cycle that leads into one another, and the codependency within the substance and the mental issues overall, which is a shame when people don't get that help from their loved ones and end up on the street, like you said, and so forth. But if people do have the funds, personally I feel if someone does have the willpower and is determined to overcome their addiction and make that step to just becoming sober, I do feel that the funds justify the end, if that makes sense, because in the long run you'll end up saving money from not buying alcohol and drugs every day and trying to keep up the rush overall. But I do feel the people that can't access the funds, that's where the NHS should come in, more or less. No, that's I feel it's obviously a big societal issue that we can't, the three of us sat here today, can't overcome and can't solve, but it's something that needs to be spoken about, I feel. And even from the private rehab side of it, I think the importance of discussing addiction overall and making sure that people know that it's not an isolating feeling or something that just occurs to them in the 1 in 100, because that's not the case. The numbers are very vast, very wide. And yeah, I feel that, and I work with people, I've known people that have overcome it and have been sober for multiple years, over 20 years in some cases, even longer. So it's not something that can't be done. So, you mentioned yourself, you've seen patients that come in and they've benefited from private rehabilitation. How do you feel they differ from people that come in that have gone through detox themselves at home, for example, or have tried to overcome the addiction without that extra help from a rehab facility?
I think that, in my experience, I can't speak for all patients, but I think they have the more mental determination that they want to get this done. Some of them have even thought about saving up money for it, or some of them have spoken to relatives, loved ones who are willing to fund that for them. And I think it's often where there's obviously denial in all addiction, but when you come to the acceptance that this is a problem and I want to do something about it, and unfortunately the NHS can't provide for you, you really then stretch your mind and stretch your finances that I want to get this done, I want to return to work, I want to now take a step. And then I think it's the mindset of patients that really changes where they come into the whole private rehab side of things.
Yeah, and how well does the NHS integrate with these private rehab facilities? Because I know we have our doctors, we have our nurses and so forth, and we do send, so depending on the person, we do send them to the doctors for referrals, especially if they have a very strong mental health issue, for example, like schizophrenia or bipolar. We make sure that that's under control before we just accept anyone willy-nilly into our rehab facilities, because we want to, yes, treat the addiction and make sure everyone's okay, but we won't do so at the at the jeopardy of everyone else within the clinic or the individual themselves. So we do keep a very close-knit relationship with GPs and doctors and whatnot, and to make sure that everyone is prescribed what they're meant to be prescribed and so forth. Do you work closely with rehab facilities within the NHS, or do you have to send medical records to facilities or so forth?
So it's so the private sector and the NHS sector do interact in many ways, but I think I don't think the integration is as good as it could be, because we don't often, when patients have come from private hospitals, for example, or patients have come from different clinics, you often don't have all the information that you need to have, and vice versa, they don't have all the information they need to have, and again, it often becomes difficult. And while we do sometimes I've had patients not specific to addiction go for private options, again, they have to apply for all their healthcare records to be released, they have to go through that process, and again, getting that approval and getting that kind of thing can take some time, and I think the integration, while it's there, it often isn't there as well.
Yeah, well, I feel like we've covered many topics today, but I can't take your time too much. I feel we have a time limit in terms of what we can do, but I really value both of your time. I thank you very much on behalf of UKAT and myself, and I look forward to speaking with you again in the future. And do you guys have any finalising comments you'd like to make before we sign off for today?
Just that you're doing a great job.
Oh, thank you. Thank you. Very, very good. Thank you very much. Saga, do you want to repeat your sentiment?
Yes, you're doing a great job, and thank you for talking to us, because I think it's always useful to get insights from different aspects of healthcare with addictions and things.
Yeah, perfect. Thank you so much, guys. It was a pleasure. Thank you.